Hi class, today we're going to talk about electronic fetal monitoring. I should have already watched a brief video describing what fetal monitoring is and how to apply it to the patient. We're going to dive deep into how to read and interpret an electronic fetal monitor. It is not in the scope of an LPN to interpret fetal monitoring. However, it's important to know for HESI and for NCLEX, and of course for our quizzes. It's also important to know what you're looking at when you are helping a client in labor, so that you can go get help when it's needed for the patient by informing either the RN or the provider available. You guys should have these slides in Canvas. Please follow along and take notes. Please write down any questions that you may have, and we can discuss them in class when we meet next, or you can email me questions as well. This next slide I'm going to skip past because it is that video that you should have already watched. It doesn't actually play when I'm recording lectures, so you've already watched that. If not, please go back and watch it, otherwise you won't understand what I'm talking about. What is our goal for electronic fetal monitoring? It's to maintain fetal oxygen supply to prevent hypoxia and asphyxia in the fetus. Why do we do it? We check to see if the fetal heart rate patterns are reassuring, meaning that the baby is well oxygenated, or non-reassuring, meaning that we need to intervene to help that baby. How do we do it? We look at the monitor strip over a period of time to assess the baseline fetal heart rate, where it stays mostly. Variability in the fetal heart rate, that's the wiggliness of the line that we're seeing. And we're going to talk about all of these coming up. We're going to look for if there is any accelerations in the fetal heart rate or decelerations in the fetal heart rate. We can do monitoring depending on what the provider has written for. So as long as everybody's healthy and nobody's at high risk, we can do intermittent fetal monitoring, where we would monitor the baby for a good 20 to 30 minutes, depending on what it's written for. And then mom can be off the monitor for a period of time, usually an hour, before getting placed back on the monitor. Or we can do it continuously if the mom or baby is at high risk, or we have an epidural in place, or we're using any other medications in labor. What does it tell us? It tells us really what's going on with the baby. It's the baby's way to talk to us and tell us how well it's being oxygenated. It'll tell us if the acid-base balance is going to be good. And it tells us if the central nervous system is working to regulate the fetal heart rate. And so we can do different interventions to help the baby if they're struggling with getting oxygen. How would we get a reduction of the fetal oxygen supply? There are many different reasons. Some of them can be maternal hypotension. Maternal hypotension can happen very often after an epidural. It's very common. That reduces the blood supply through the placenta. Maternal hypertension, same thing. Too much pressure reduces blood supply through the placenta. Maternal smoking, if she smokes. If she's anemic, smoking causes vasoconstriction of the vessels, and so that decreases the blood supply through the placenta. And anemia, of course, our red blood cells can't carry enough oxygen to the tissues if mom is anemic. If we have decreased blood flow through the placenta through too many contractions, every time the uterus contracts, it squeezes off that blood supply through the placenta. So we want, when we have contractions, we want them to be short, not too long. And so when the uterus relaxes, that blood supply is restored. We can have what's called tachysystole, where we're contracting for way too long, cutting off that blood supply to the baby. And also, we can have too many contractions in a row, which doesn't allow for full flow to return to the placenta after the contraction. That's tachysystole, either too long of a contraction or too many contractions. Also, we can have deterioration of the placenta. Usually that's after we're past our due date, so 41, 42 weeks and so on, will make the placenta start to deteriorate. Changes in the fetal heart rate can result in decelerations. So the heart rate will slow for different reasons. The baby can become stressed and become tachycardic. Baby can also become bradycardic. If the placenta starts to separate from the uterus, it can result in hemorrhage. And then also we have what's called RH incompatibility, where mom's blood may attack the fetal blood, which decreases the fetal blood supply. So all of those reasons can reduce fetal oxygen supply. Hopefully by now we've already learned proper positioning of the mother. If not, we want to make sure our moms after 20 weeks are placed on their side. Left side is preferred, and you'll always choose the left side in any questions. However, moms can lay on their right side. It's just slightly better if they lay on the left side. If you look in these two images here, the one on the bottom is showing mom laying on her back. And we have these two vessels that supply most of the blood supply to the placenta. And when mom is laying on her back, the uterus is so heavy that it compresses those vessels and reduces blood supply to the baby. And so she should be either all the way on her side, left side is what you're going to choose, right? But right or left, or with a slight tilt with a pillow to relieve pressure off of those vessels so that we can have excellent supply to the placenta blood supply. If mom's been laying on her back for a while and she suddenly sits up, we can have what's called supine hypotension, where mom's blood pressure will drop significantly when she stands up, and she could pass out. So very important that they're laying on their side, or at least with a tilt to be off of those vessels. We're going to talk about external monitoring first, where we would apply monitors, 2 belts and monitors to mom's abdomen so that we can measure uterine contractions and fetal heart rate. In this image here, the monitor under the blue strap is placed at the fundus, the hardest part of the fundus. Usually on the bottom if the baby is presenting head down, or the baby's head. So the hardest part we're going to find on that fundus, and that's where that monitor is going to go. Monitor is going to monitor contractions. It has a little button on the underside of it, and as the uterus contracts, it slowly pushes in that button, and then as the uterus relaxes, it relieves that button. So it makes those mountains, those nice mountains on the monitor for us. One underneath that, and the pink band, is the fetal heart rate monitor. Usually babies are in the head down position, so this would be placed lower on the abdomen. If the baby is breech, it would go right up top with the contraction monitor as well, so that we can get a good, clear heart rate. This fetal heart rate monitor is ultrasound, an ultrasound device that picks up the heart rate, and so gel is usually applied to that so that we can get a good connection. Before we place that fetal heart rate monitor, we want to make sure we know what position the baby is in, So that way you're not startling mom by not finding the heart rate quickly. We do what's called Leopold's maneuvers to see what position the baby is in. So in this image in A, we're going to start at the fundus, palpating on either side. We're feeling to see which part is at the top. Is it smushy, which would be the tush, or is it hard, like the head would be? We're going to continue down on each side. On the sides, we're going to feel, is it firm where the fetal back is, or do we feel small parts and a little bit smushier on this side? We'll continue down to the pubic symphysis right above, and we're going to feel on either side. And hopefully there's a head there because that's the way we want the baby to be facing. Should be nice and firm. And the way we tell the difference is we can wiggle our hand and the fetal head will move. And if it's the bottom, the tush will, the whole body will move. It's not as movable there. It's also more firm when the presenting part is the head. This movement, the nurse or a practitioner will move opposite the, I guess, toward the head of the patient. And that's just checking to see if the fetal head is tucked, with the chin tucked. We want them presenting with the back of their head first. And so that's just getting a feel for if that chin is tucked in. Now, that will get the best fetal heart rate when we place the monitor over the fetal back. So in this image, in actually all of these images, the best place for this monitor placement for this baby would be on the maternal left lower quadrant of her abdomen, because that's where the fetal back is. If the baby were facing the other way, it would be over on the right side, but in this image, it's the maternal left lower quadrant for proper placement of this monitor. This is a video on Leopold's maneuvers. I'm going to have you guys watch that one on your own as well. We'll probably even play it in lecture. When we're talking about, when we're looking at our fetal monitoring strips, usually we see it electronic nowadays, but this is a old school paper that we used to print out. It'll look just like this on the screen as well. But we need to know a few things when we're looking here. We need to know that each dark line on this strip is 60 seconds long. In between these little lighter lines is 10 seconds. So we have a dark line, and then we have 10, 20, 30, 40, 50, 60 seconds in between each dark line. So 1 minute is a dark line, 10 seconds is a lighter line. Also, we're looking at the top here, you'll see a wavy line come up. That's going to be the fetal heart rate. Sometimes you'll see two lines, and that's usually the fetal heart rate and mom's heart rate. We have a pulse ox on her so that we can see the difference between the two, because sometimes their heart rates may be very close, and we want to be able to prove that we were actually monitoring the fetus. And so we'll have a pulse ox on her, but I don't think there's any examples in this showing you that. Normal heart rate range for a fetus is from 110 to 160. You see these dark lines here. We're at starts at 30, then 60, 90, 120, 150, 180, 210, and 240. And then each light line is 10 seconds in between. On the bottom, you'll see the mountains or the contraction monitoring. And it's the same. Each dark line is 1 minute, and then each light line is 10 seconds. And then you'll know the strength of the contractions depending on where it falls. It doesn't look like there's any numbers on this particular strip where it falls on those lines. Again, it'll go up 10 every light line. Now we can see it a little bit better. So just like we were talking about, all the dark lines are 1 minute. In this blue shaded area is our normal fetal heart rate range. Electronic monitors will have that highlighted for us, which makes it nice and easy. And again, that highlighted area is from 110 to 160. So if the heart rate falls anywhere in there, it is a baseline fetal heart rate. On the bottom, you have mountains. Those are our contractions. And the strength on the side here goes up. The dark lines are 25, and then the light lines are 10 in each increment. When we have an external contraction monitor, these mountains, the height doesn't really matter. It doesn't tell us the actual strength of the contraction. It can be placed on kind of a softer spot on the abdomen and pick up weaker, or a really hard spot and pick up stronger. And we can only determine the strength of the contraction by palpating the contraction, or by asking the patient how strong the contractions are, her pain level. The way we determine by palpating the contractions is by feeling the abdomen or the uterus as it contracts. We'll feel and palpate it. When it's a mild contraction, the uterus will feel like our nose. If you touch your nose, you'll feel the uterus is kind of squishy. And then moderate or medium would be our chin, touching our chin. And then a strong contraction would be like touching our forehead. This is just another image of a fetal heart rate strip. So in this strip, if we were to determine the fetal heart rate baseline, it would be like drawing a line through that and seeing where the heart rate bounces the most. And so in this particular strip, I would probably say the baseline fetal heart rate, if I drew a line through, would be about 145 or 150. You can be off by a few beats, and that's okay. So I would probably say 145 for this one. Our contractions are every let's see, 3 minutes apart for this strip here. When we look at contractions, we're looking at the duration, which is how long they last from start of one contraction to the start of the next contraction. We're looking at the frequency, how far apart they are. That goes from the start of one contraction to the start of the next contraction. And we're asking or palpating how strong they are if this is an external monitor. If it was an internal monitor, it would tell us exactly how strong they are. Here's just another image of what I was talking about on monitoring the contractions. Again, duration is start of one contraction to end of that same contraction, how long it lasts. Frequency is start of one contraction to the start of the next contraction, so how far apart they are. And then intensity really only counts if we have an internal monitor inside telling us exactly how strong they are. Otherwise, we have to palpate mild, moderate, or firm or severe. Determine the strength. We'll also look at resting tone. Does that uterus come back down to its baseline in between contractions, refilling the placenta with blood in between? This slide is just telling you about how we feel for contractions, how we palpate, mild, moderate, or severe, nose, chin, and forehead. And also asking the patient what her pain level is. This is a picture of tachysystole. We already talked about it, having too many contractions, which is defined as more than 5 contractions in 10 minutes, or too long of a contraction, which is defined as lasting greater than 120 seconds long. That baby's just not getting enough blood supply because we're contracting too much. Tachysystole. If we look at fetal heart rate patterns, we're looking at the baseline like we talked about before. Remember, it's 110 to 160 is our baseline fetal heart rate normal range. We round it to the nearest 5 beats per minute, so we can get pretty close, or we can be off just a little bit, right? We need to look at it over a 10-minute period at least to interpret it. And then we're looking for different changes in the baseline fetal heart rate. The other thing we're looking at is what's called variability. Variability is the irregular fluctuations in the baseline fetal heart rate. In those few strips we've already seen, you notice that that line is very wavy, right? That is variability. That's telling us that the central nervous system is working, the baby is getting enough oxygen, by the parasympathetic and the sympathetic nervous system pulling at each other. It makes that line bounce, and that tells us how well that baby's doing. This is just showing you determining the baseline fetal heart rate. We've drawn a line, imaginary line, but it's red here, through where that heart rate bounces the most. And in this image, you would probably say the baseline fetal heart rate for this strip is 130. And we know that that's normal because it's anywhere from 110 to 160, right? That's the baseline. So in this one, baseline fetal heart rate is 130. And we're going to look at the variability. Remember, it's fluctuation, that bounce in the fetal heart rate strip. Remember, variability is the single most important characteristic of the baseline fetal heart rate. So how wavy that line is the most important. It tells us a lot that's going on with that baby. And there are 4 different types of variability. We can have absent variability. That's kind of like asystole on an EKG strip, right? There's no movement in that line. So 0 beats of fluctuation in that heart rate. That's bad, never a good thing. Absent variability is always bad. We need to have a baby. We can have minimal, that's less than 5 beats per minute change in the variability or the squiggliness of that line. Minimal can be bad if we know that it's from not from something that we've done to the baby, okay? So minimal can be if the baby's sleeping. That's okay. They're allowed to sleep. We let them sleep for 2 hours. If it's actual, we're monitoring them for that long. Then we're going to try to wake them up and see if we can get that baby to wake up and get more variability. We can also have minimal variability if we've given a narcotic. It makes baby sleepy just like it makes us sleepy. And that's okay too. We know we've done something to induce that. Any other reason, minimal can be bad. Okay. Moderate is what we want. We want moderate variability. It's a good bounce in the line from 6 beats per minute to 25 beats per minute. So it's a very squiggly line there. That's what we want. That tells us that our baby is doing well and is well oxygenated. We can also have marked variability that's greater than 25 beats per minute. This line is very squiggly, and this is also a bad sign. This is our baby is not doing well, and we need to have a baby very quickly to make sure that our baby is not harmed. In this strip here, we see moderate variability. So this bounce in the line, see here, fluctuates at least, let's see, it goes from about 125 all the way up to 135. So it's greater than 6 beats per minute, squiggliness of the line. Different images of the different variabilities. Minimal, again, 1 to 5 beats per minute. We have some fluctuation, but not a good amount, right? Moderate is what we want, anywhere from 6 to 25. That means our baby is doing well. It's well oxygenated. We know that baby is okay. No bounce in that line at all. That's very bad. Oh, and sorry, I don't think I talked about marked. Marked is very squiggly, greater than 25 beats, and that's also bad. So the 2 on the right side are bad. 2 on the left, depending on what's going on with that minimal, could be okay, but we need more information. Moderate is what we want. All right, so looking for changes in our fetal heart rate. When we look for accelerations represent fetal well-being. Baby is doing good. It's always reassuring. It's caused by the baby moving. If you were to run down the hallway, your heart rate's going to increase, right? So if baby moves, their heart rate increases. That is good. That means our baby is well oxygenated and doing well. And that's why I put that cute little smiling baby on your slide. This is good. What we do with this is we just continue to monitor. It's never, we don't do anything, right? We always are going to continue to monitor. This means that baby is doing well at this point. The criteria for accelerations is an abrupt increase in the fetal heart rate above the baseline, but it needs to be at least 15 beats above the baseline and last for 15 seconds or longer. So 15 by 15 is what we say for that. See here, it goes above the baseline, and this one's probably lasting a good 30 seconds. This one is probably even a minute here. So it's going up at least 15 above the baseline for 15 seconds to be considered an acceleration. And remember, accelerations are good. It means our baby is doing well and well oxygenated. Another example of accelerations. And some more. Okay, let's go back. Our baseline in this image here would be 130. And we have accelerations. There's 2 present in this, just as a 1, 2, 3 minute strip. This one, if we're looking at our baseline, let's see here, we have 120 and 150 here. So I would probably say, if I were to draw a line through it, I'd say this is about 145 is the baseline. And we have 3 accelerations, 1, 2, and 3 present in the strip. All right, so if we have tachycardia is a fetal heart rate baseline above 160, okay? We need to review the fetal heart rate overall. So if it's been more than 10 minutes, then it would meet that criteria. And then it's usually a maternal issue that's causing this. Usually she has a fever, okay? But we're going to assess all these other things. We're going to look at her vital signs. We're going to look at her hydration. Is she dehydrated, and is she tachycardic, causing fetal tachycardia as well? Did she use drugs? That can cause the fetal heart rate to increase as well. And we would need to perform an ultrasound if we couldn't figure out what was going on. What could be another cause of fetal tachycardia? Think about it. Since this is a recorded lecture, I'll go on. But it could be an energy drink. Energy drinks increase the maternal heart rate. Look, I got one right here. Which also increases the fetal heart rate. So if we have tachycardia and a patient has just come into OB triage, we usually say, hey, did you have an energy drink on the way over? Sometimes they say yes. They really shouldn't be drinking it in pregnancy, but we don't judge them, right? Fetal bradycardia Definition is a fetal heart rate less than 110 beats per minute for greater than 10 minutes. Fetal bradycardia can be caused by fetal anemia, RH incompatibility, things like that. We're going to talk about decelerations coming up, but when we know that there's something wrong with the baby, the fetus, with the strip that we're looking at, we can do a few things. We group these things and term them intrauterine resuscitation. So resuscitation of the baby, we're helping the baby in the uterus. It's kind of like baby CPR, fetal CPR. So that's why I put this image here. What do? We stop the oxytocin. Oxytocin is what causes contractions if we're making them stronger. We want to rest that uterus so that we can increase blood supply to the baby. We change the patient's position. So if she's on her left, we're going to put her on her right and vice versa. Or we can put her in high Fowlers. That would help. We're going to apply oxygen. When we apply oxygen, it's always 10 liters in OB, obstetrics. Always 10 liters via non-rebreather mask. Even go up to 15 liters, but we never apply nasal cannula in OB, labor and delivery, or in postpartum either. It's always go big or go home. They get 10 liters non-rebreather mask, excuse me. We're also going to bolus IV fluids. At least a 500 milliliter bolus to increase her blood volume and get that blood flowing to the baby. That's called intrauterine resuscitation. And we would do this if we had different types of decelerations. We'll talk about which ones coming up here. Decelerations are a decrease in the fetal heart rate from the baseline. And they're described by their shape and visual relation to the onset and end of a contraction. So it's compared to a contraction, and what does it look like? These are early decelerations. Early decelerations indicate head compression, and they are a normal sign of labor. That means that the baby is moving down through the birth canal and the head is getting compressed. It's good. It means that labor is progressing, okay? It's nothing that we need to do. I know it says none, and I already said there's never nothing that we do, right? But what we do is just continue to monitor this patient. We know that labor is progressing. This is a good sign. Usually we'll have moderate variability in between, and moderate variability, as you all know now, is the most reassuring of our fetal heart rates. If you look in this image here, the deceleration, so when the heart rate goes down, when it drops down, it mirrors the contraction. So if we were to flip this upside down, they would look the same, okay? As soon as the contraction starts, that heart rate goes down. As soon as the contraction ends, that heart rate comes right back up to baseline. And that's called an early deceleration. It mirrors the contractions. In this image here, we're talking about late decelerations. You have a crying baby. This means baby is telling you, hey, I'm not okay in here. I need you to fix me. Late decelerations are bad. They are caused by uteroplacental insufficiency, lack of blood flow through the placenta. There can be many different reasons for this happening. But know that it's lack of blood supply through the placenta, and we need to fix this. We need to do that intrauterine resuscitation. This one, if you look at this image here, the heart rate, the fetal heart rate will decrease after the contraction has started, usually at the peak of the contraction, and it doesn't come back to baseline until after the contraction ends. That's why we call it late. It recovers late after the contraction ends. Remember, late decelerations are bad. We need to do something to fix it. If it continues and we've done all of our intrauterine resuscitation, then we need to move to a C-section and get that baby out. let's see. It could be because we have maternal hypertension or hypotension, or we're having too many contractions, or contractions are too long, lasting too long, tachysystole. We could have given her recent medications causing decreased blood supply, and anesthesia, like I said. The most common cause of maternal hypotension in labor is due to the epidural. It can cause hypotension, and that would cause our late decelerations as well. What do we do? Intrauterine resuscitation. We're going to stop oxytocin if she's on it, change her position. O2, 10 liters, non-rebreather mask. Give her lots of fluids. Increase her fluids. Usually we just take it out of the pump and run it wide open as fast as it'll go. We need to help that baby. And then we need to assess what is causing this so that we can fix it. This is a variable deceleration. See how it's V-shaped in this picture here? It can be V-shaped, U-shaped, or W-shaped, but the definition is an abrupt decrease in the fetal heart rate, less than 2 minutes, caused by cord compression. So somehow that cord is being squeezed inside and cutting off the blood supply to the baby. Usually changing mom's position can help that baby get off of the cord. But remember, they are alive in there and they have a grasp reflex. So if they touch their cord, they can also hold on to it because they have a reflex to grab that cord. And sometimes when their heart rate drops, they go, oh, and they let go really quickly and it comes right back up. And so remember, cord compression is a variable deceleration. What do we do about it? We can change her position. If it happens frequently like this, we're going to start to move toward a C-section because that baby's not going to like that very long. So yeah, change her position is what we're going to do for variable decelerations. If it's happening then we can do our intrauterine resuscitation where we would put the O2 on as well and give her a bolus of fluids. We can also insert a catheter into the uterus and increase the amniotic fluid by using normal saline to cushion that cord if necessary to help those variable decelerations. This is what we do, which we actually just talked about. Our plan or treatment, change her position, get that baby off the cord, do a vaginal exam to see if we can feel the cord or see if her labor is progressing. And we can do amnio infusion. That's where we put the saline back into the uterus to help cushion that cord. This one I don't want you to worry too much about for testing purposes, but this is a prolonged deceleration. It is a decrease in the fetal heart rate greater than 2 minutes, at least 15 beats below the baseline. This one is really bad. Of course, it's kind of like the baby's holding its breath, right? For greater than 2 minutes, and nobody can do that, right? Well, maybe some people. But that's a long cut off of the blood supply. So this is bad. We would want to do all of our intrauterine resuscitation. If they're on Pitocin, oxytocin, stop it, change her position, apply oxygen, give a bolus of IV fluids. I know that sounds like a lot, but we do this quite often in labor and delivery. And we can do this on our own, all 4 of those things, probably within 1 minute, because we do it so much. We need to figure out, whoops, my battery's gonna die. We need to figure out what's causing it. Did the patient's heart or blood pressure drop from an epidural? That can cause it. So we would give what's called ephedrine to increase their blood pressure. Stop the contractions if they're having too many. That's tocolytics, different types of medications to stop the contractions, which we'll talk about in lecture. and prepare for a C-section. If the heart rate doesn't come up, we're running back to the OR. We can get a baby out in 5 minutes if necessary. If we get that heart rate to come back up, then we'll continue to monitor. If the baby does it a second time within 12 hours, then we're going to have a C-section regardless, because we don't want to mess around with that baby dropping its heart rate that much. We use this mnemonic to help remember what to do with each of these different variations in the fetal heart rate. So we use veal, chop, and then mine. Veal is the pattern, chop is the cause, and then management. What do we do? Okay, so veal, V is variable deceleration. It indicates cord compression. What do we do about it? Reposition mom. E is early deceleration. It indicates head compression. We identify labor progress. So we could do a vaginal exam, but we really know that labor is progressing, so it's not necessary. We would only do it unless we needed to. Or we're curious to see what was happening, I guess. Or we don't want to do vaginal exams just because we're curious, right? A, acceleration. It means the baby's okay. It's doing well. What do? Never nothing, but it says no interventions, meaning we're just going to continue to monitor the patient. L is late decelerations. That's bad, right? It indicates placental insufficiency. Placenta is not perfusing the baby. What do? Execute all the interventions. We got to fix it. This is different ways that we classify fetal heart rate tracings. I don't want you guys to worry too much about it because LPNs cannot interpret strips, and so it's not going to be something that you're tested on. However, when you do make it into block 3, you will need to know the different categories. I do have it here just so you know. These categories tell us exactly what to do. Category 1, our baby's doing fine. We can have early decelerations and accelerations absent or present for category 1. Category 2 would be some maybe some occasional variables and prolonged decelerations, only 1 in 12 hours. Minimal variability can give you a category 2 depending on what's happening. Absent variability without recurrent decelerations can be a category 2 depending on what's happening as well. And bradycardia there too. Category 3 is moving towards a C-section. We need to have a baby in that category 3. So this is either absent variability with recurrent late decels, or recurrent variable decels, or bradycardia, or what's called a sinusoidal pattern. That's where the heart rate makes a patterned wave like image on it. I don't want you guys to worry too much about that because you won't be tested on it. But that indicates fetal anemia, maybe from RH incompatibility, or maybe it's a twin-to-twin transfusion happening there, or a placental abruption. Just means that the baby doesn't have a lot of blood present. That again is bad, so we need to figure out. Signs of an increasingly distressed fetus. We have that marked variability going on in this strip here. Can have absent accelerations, a gradual increase in the fetal heart rate baseline. We can have loss of variability. We can have the late deceleration pattern, and then the decelerations will gradually increase in length and take longer to recover to baseline. If we have persistent bradycardia, if we have all of these things for too long, it can result in fetal death. Strip down here, we have some variable decelerations. We have marked variability coming up here toward the end, and then a prolonged deceleration. Now, I know that this baby was okay because it wasn't down for too long, because here it says delivered. She delivered at 2021. And so they were working real hard to get that baby out vaginally here. So she was pushing, and that's what was causing this deceleration. Maybe the cord was wrapped around the neck or something like that. We can also do internal fetal monitoring if necessary. Internal fetal monitoring, of course, increases risks to mom and baby and risk of infection. We can use an intrauterine pressure catheter, or IUPC, to monitor the strength of the contractions, the actual strength, to see if our contractions are strong enough to dilate a normal cervix. Or we can use it to do that amnio infusion that we talked about earlier, putting the saline back into the uterus to cushion the to cushion the cord. And then our internal heart rate monitor for the baby can be placed on the baby's head. It's a little spiral needle that gets screwed into the baby's head. I know that sounds mean. Actually, it doesn't hurt. I've put it into my hand before. I'll show you guys this in lab or theory. The little device that we screw onto their head, and then we can monitor that heart rate closer. So if we're having a really hard time keeping the baby on the monitor, or we're having lots of decelerations and we want to monitor really close, we're going to put that external fetal monitor in. And nurses, RNs can place this. It doesn't have to be a provider. A provider does have to place the intrauterine pressure catheter, though. All right, you guys can hit that link to practice EFM games, but we'll also practice those in class as well. Again, if you have questions, please let me know, and I will see you guys all soon. Thank you.